Well, I'd like to welcome everybody today. Really excited about this topic. It might be a new topic for many of you. Today we have our Canadian colleagues, but in addition to that, we have our colleagues from the South, our dear neighbors. And so really a warm welcome to our American Wound Ostomy Continence participants as well. I had the opportunity to do my training down in Atlanta, Georgia with Dorothy Dowdy at Emory Medical University. And so I have fond memories of my time and my experiences there as well. But let's move along. Today, we're going to talk about continuous diffusion of oxygen. I'm going to start us off, and then Dr. Campbell will join in, and then later Kathy Mutch will also be joining us. Both Kathy and I have no relevant financial interest to disclose, and Dr. Campbell is a consultant for EO2. So we're going to jump off this session actually right away with a case study. And it's a very recent case study, really impacted a patient of mine, and it was related to a surgery of breast reconstruction where there had been a reperfusion injury. And we needed to see what we could do to enhance the blood flow to this area. It's a 66-year-old lady. She had had surgery on October 21st, right breast nipple sparing mastectomy, and a right immediate breast reconstruction with the tissue expander, and the alloderm was there as well. But it was on a previously irradiated side. So 20 years previously, on that same breast, she had had radiation, and of course at the time had had chemo. And so we realized at the time, the surgeon was well aware that this was a high-risk procedure because tissues that have been radiated are more at risk. Following surgery, there was an area of tissue necrosis, and you'll see that on November 16th, this was particularly discouraging because we thought, with the tissue expander being close and the alloderm, what were we going to do? There were thoughts of the patient was even entertaining going to hyperbaric despite being in the midst of COVID. And instead I said, look, rather than that, why don't you stay close to the team, your surgical team, your wound team, and we're going to try continuous diffusion of oxygen. So how we proceeded with that, and she was more than willing, we introduced a little unit and a dressing. And in this instance, as we proceed with the next slides, we started at 3 milliliters per hour of continuous diffusion of oxygen. And the oxygen goes through a small tubing to a foam dressing. And in this instance, I did use a methylene blue gentian violet dressing and a non-bordered oxygen diffusion foam dressing on top. And later I include some photos of that, so you get a picture. The next slide, you'll see the methylene blue and how we laid that on the wound bed, secured the dressing, and I tend to, making sure the dressing doesn't slip, use a bit of strip paste around it. The patient wore an easily chargeable unit. As you can see, that handheld unit, it's actually quite light. And she would carry that or attach it. There's a carrying case, attach it to herself. You can already begin to see by December 4th, there's some more, a bit of granulation tissue, pinker tissues. Next slide. By 14th, we're definitely seeing substantial improvement, and we're pushing away the notion that she would be going to hyperbaric, as we felt that this oxygen unit alone was actually transforming the wound bed to a more granulation tissue. You could just see that it was better perfused and the area was becoming smaller. Next slide. I think December 23rd, which I guess, as you can appreciate, it was just before Christmas. And she really felt that this particular unit was a Christmas present to her, because you see, there was the real threat that she would have to have surgery. And we wanted to do everything possible to not go back and do surgery on a very high risk situation. And so there was a great deal of joy as we approached Christmas that we were now knowing we were well on our way to an area that was healing well. Next slide. And so as we progress, again, just still using the same products, continuing on, next slide. We got to the point that the plastic surgeon said, Rosemary, this is so good. I'm just going to approximate the edges. We're going to leave those sutures in place, and we're going to watch it carefully and continue with these continuous diffusion of oxygen. And the next slide, you'll see by the 25th, it was closed, and she has not reopened. And we are now, in April. So it's a very, for me, there's another piece about this story that I think is important. This patient struggled with depression. So you can imagine how disheartening it was when she woke up from her revision surgery to see this wound, and she just didn't know what would happen next. So it was wonderful to see her, the anxiety lessen, and have a very successful outcome. And so I'm going to move the next portion of our presentation, though, to Dr. Karen Campbell, because I want her to explain a little bit about the science behind this therapy. Now, Karen is going to introduce herself. I think I forgot to introduce myself. My background is, as I mentioned, a wound ostomy continent nurse trained at Emory, but I work at Lionsgate Hospital, Vancouver Coastal Health, and I've been CWOCN or an NSWOC for about 16, 17 years, but a nurse for about 40 years. Karen, I'm going to pass things along to you. Take it away, Dr. Campbell.
Thank you, Rosemary, and thanks to everyone for joining us tonight. My name is Karen Campbell. I'm a nurse in Canada. I am as well a certified wound ostomy continence nurse here in Canada. I've been involved in wound healing since 1992, and like Rosemary, I've been a nurse for many, many years. My area of specialty is really, although I'm a WOCC nurse, my focus is more on wound care and continence. And so the objectives for this evening's session are to review the evolution of oxygen in wound healing, discuss features of CDO therapy. I'm going to provide some literature and case studies to show you how CDO works, how CDO improves wound pain management, and what the cellular response is to CDO. And we've got some exciting research to share. And then Rosemary's presented a case, but Kathy and myself have other cases to present. And I have a case I'm going to show to you where a patient was able to self-manage their wound care and use virtual wound assessments to see their clinicians. So what is the evolution of oxygen therapy? And we compare it to a telephone because, as you can see, the size of a cell phone is similar to the size of the CDO unit. Got to go back one more time. And so, as you can see, when hyperbarics started in the 50s, you needed to have a large chamber. Patients had to travel, just as we had, tethered telephones. And with technology improvements, now we're down to very small, portable CDO units, similar in size to a cell phone. And this actually shows what the unit looks like and what the dressings that accompany the unit looks like. And so you can also see there's a carrying case so that patients could either wear this unit around their waist or on their legs, whatever position is appropriate given the location of their wound. And now I'm going to start talking about some of the high-level evidence that we have regarding CDO. The first study I want to talk about is a study with diabetic foot ulcers. It was a placebo-controlled, randomized, double-blinded, multi-centered study. And you can see in the active arm, patients got CDO Everyone was offloaded with an offloading boot. Everyone had moist wound healing dressings in place, as well as the oxygen dressings. And if you were in the active arm, the system was preset at 3 mils per hour. And so the oxygen was flowing 24/7. And if you were in the placebo arm, you actually had a unit, but there was no oxygen flowing to the wound, even though the system was preset to 3 mils per hour. But all of the other treatment was the same, other than the active arm received CDO and the placebo arm received nothing. The primary outcome was full wound closure, defined as complete reepithelialization with no drainage. But secondary outcomes were time to wound closure, effective baseline wound size on wound closure, and effective chronicity with wound area reduction on wound closure. And there were 146 patients in 34 centers across the continental US. There were no significant differences in the arms. So you can see the wound sizes, the average age was in the 50s, the racial makeup, and the gender, more were male than female. But of interest, all but one patient performed their own dressing changes outside of clinic visits. So that's an important factor when you're thinking about self-management. And so the time to closure was significantly shorter with CDO for all treated subjects. And you can see there that the p-value was 0.015, and the time to 50% wound closure was significantly shorter with CDO therapy. And that was 18 days in the CDO therapy versus almost 29 days in the sham arm. And that was statistically significant as well. What was really interesting, as the wound size increased, relative performance of CDO improved as well. And so there was more benefit for larger wounds. And you can see here the relative performance does increase almost up to 300%, but not quite. The other interesting finding is that as wounds increased in chronicity and they were less responsive to moist wound therapy, the CDO relative performance increased from 200% to 300%. And the p-value went from 0.016 to 0.008. And so what we take away from that is the more your wound is chronic, the more one needs CDO, the better it performs. And again, look at the response here, going from 200% up to 340% almost. So in summary, this was a rigorously fully blinded study designed with a placebo arm, and everyone was blinded. Patients, participants, physicians did not know who was getting the active treatment. There was a run-in period to screen for wound chronicity, and I believe that is very important in this study, because in the run-in period, with debridement, with moist wound healing, with offloading, if the participants' wounds were healing really, really quickly, they were not included in the study. Only wounds that were not healing at the rate that you would expect were included in the study. We had highly accurate digital photos, and we had planimetry to determine wound size. The US CMS cited this study design as the gold standard for studies going forward. And in summary, CDO closed significantly better and faster, over 200%. CDO performed better in larger wounds, more chronic wounds, in weight-bearing wounds, in populations predisposed to diabetes, and in frequently debrided wounds. And in the Hispanic population, the healing rate increased to 382%, and almost 82% of those wounds closed. And the other thing that we found in the CDO arm is that there were 75% less severe infection. So that's a very important result for patients with diabetes. So now I'm actually going to tell you a story of one of our other colleagues that works with us, Edie Trell. This is one of her patients. And you're going to listen to a little story to begin with.
Changing the dressings was no problem. It was actually quite simple. once you had the confidence, it took just a matter of short minutes to unscrew tubes, take off dressing, put new dressing on, and then re-hook it up. During the time period, the wound got smaller and smaller, which was nice. But during that time, I did have electronic access via text or pictures to the clinician, and was able to just discuss it as it was proceeding. So although I was doing all of this at home, it was as if someone was with me. The wound, as I said, got smaller and smaller, and hopefully in the next week or so it will have gone away. I had good results, and I'm very happy with the use of it, and when I look back on it, it really was very simple process. So I am quite happy with the results.
Great. And Bill's wound went on to close. And so let me tell you a little bit about his background. 73-year-old man, he was pre-diabetic. He had marginal venous insufficiency. And in March of last year, he had a small red area on his lower leg. His treatment initially was to leave it open to the air, as often you hear from your patients, and to use a Band-Aid, but he then developed contact dermatitis, and then he switched to gauze. Initially, he was managing this wound on his own, and later home care nursing became involved. So you can see on April 30th, the ulcer was quite painful. You can see the size there. There was slough present, poor granulation tissue, peri-wound erythema, but it was not warm to touch. And the initial treatment plan with his home care nurse was cadexamer iodine in a foam dressing for 2 weeks. There was a request from the clinician to have a lower leg assessment, and he had 20 to 30 millimeter compression stockings, but he wasn't wearing them. So he was asked to restart wearing them, and he was moisturizing his leg because it was dry and itchy. And so he did have a knowledge deficit. So the wound clinician then taught him how to look for changes in wound bed colors. So is the wound sloughy versus is it granulation? He was also taught to look for changes in exudate levels. And was the dressing change frequency changed due to the amount of exudate? He was taught about hand washing, wound assessment, dressing changes, and storing and carrying of supplies. He was sending pictures. You can see the pictures that he would send to his wound clinician. And you can see that May 15th, after doing all of these interventions, there was little change, and CDO was started. And CDO therapy a month later was continued, but an antimicrobial primary dressing was added to help with his wound healing. And he would actually draw pictures and send notes to his clinician to describe what was going on in the wound. And we show you this as an example for how your patients could participate even if you had to see them and assess them virtually. And in conclusion, after 2 months of topical wound therapy that he was doing at home, the wound was larger. 2 months of care by home care nurses with moist wound healing, the wound was stalled with little change, but after 3 months of CDO therapy, the wound closed. But remember, this therapy was done in combination with his compression. He was independent in his dressing changes. The EO2 consultant did assessments by photos, phone calls, and periodic home visits. And he was provided with education and ongoing support. And we realized that this was a fairly cost-efficient outcome. And in the face of COVID, with the reduction of face-to-face visits, how relevant this was for his care. So now I'm actually going to switch over and talk a little bit about our study that looks the effect of CDO on pain and treatment of chronic wounds. And you can see the reference there. And this was a pilot study with 20 patients in 23 wounds Most were female, and it was done in Chicago. You can see the average age is older than the diabetic foot ulcer, and the wound size was bigger. And you can see that one of the wounds was 117 centimeters squared, but the wound size were anywhere were 15 with a standard deviation of almost 28 centimeters squared. You can see that these wounds were chronic. The average age was 162 days. And the standard deviation was plus or minus 115 days. You can see the race makeup, and you can also see that the median baseline pain score was 8 on a scale of 0 to 10. This slide shows you what the wound types were in the pain level. So the traumatic wounds, although there was only one, the pain score was 9. The most common wound type was mixed venous and vascular, and you can see that was quite painful. So the primary wound type was mixed venous and vascular, and they were all lower extremities. 87% were above the malleolus. All patients reported significant wound pain relief. 100% went to either a 0 or 1 with an open wound. Pain relief was fairly rapid by day 4. 39% were pain-free. 52% had a greater than or equal to 75% reduction in pain, and 91% experienced noticeable pain relief. And several reported complete pain relief the day of CDO application. And what happened in terms of wound closure? So 83% experienced significant or complete closure. That one wound that was 117 centimeters square actually closed, and the pain score in the wound went from a 10 down to a 0 at the first follow-up. And in wounds that generally did not close, pain relief was dramatic. And so 75% were pain-free by the first follow-up visit. And CDO enabled stopping the use of narcotic painkillers with many of these patients. So now I'm going to turn it over to my colleague from PEI, Kathy Mutch.
Hello, my name is Kathy Mutch. I'm an NSWOC of 35 years. I've been very fortunate to have been able to participate in our Canadian Association on a number of activities. For example, in the development of our Canadian NSWOC academic program, in the development of the certification program. I've been an academic advisor, education chair for 3 national conferences, and Atlantic Regional Director. I welcome and I'm glad you're here to join with us today. The case study I'm going to share with you is about a young woman in her 30s who had a chronic, painful, non-healing leg ulcer. She had a very significant past medical history and quite complicated with drug use, hepatitis C, on methadone program. She had a native valve endocarditis, chronic anemia, PTSD, depression, ADHD, borderline personality disorder, and really struggled to adhere to a therapy plan. I've known her on and off for at least 4 years with this leg ulcer. We had tried numerous things, and she had been in hospital requiring intensive care for sepsis on numerous occasions. When she arrived to Emerge, they called me down to visit her, and I found her to be extremely frightened, agitated, and in extreme pain. She could barely allow air to pass through the room without becoming increasingly agitated. I spoke briefly and did get a chance to have a look at the wound, and then went to speak with her medical team to create a plan. Her plan included admission. I really felt that if we were going to get anywhere, we had to have her in a situation where we could control what was happening and provide her with the best care. That was agreed upon, and her addiction team was also heavily involved. They had made some adjustments to her medications, which had created some of this pain crisis, and she certainly wasn't able to manage without a good intervention for pain and addiction issues. So when I did go back to see her the next day, her wound was 9.5 by 6.2 centimeters. eschar covered about 85% of the center of the wound, 15% of the wound bed. Around it was red, but really poorly granulating, very unhealthy. And again, she remained hypersensitive to stimulation. Her pain was, if I asked her 10, it was way above 10, she indicated. So I'm going to go through some of the treatment plan and how this wound progressed with the use of continuous diffusion of oxygen. So this is March 18th, a day after admission. Sorry, the quality is not great, but you can see that it was certainly not doing well. Granulation tissue, there was a little red, but very poor, and eschar covered. Normally, the recommendation would be to remove necrotic tissue before starting continuous diffusion of oxygen, but she would not have tolerated going near her to remove any of that necrotic tissue. But fortunately, a couple of days later, even over the necrotic tissue, you can definitely see changes happening. The granulation tissue is becoming healthier, stronger, more viable, and the necrotic tissue is hydrating well and beginning to soften and lift at the edges. By March 25th, I was able to actually, not surprisingly, I was able to debride it. Her pain management had improved so well with the treatment of her team, as well as with the continuous diffusion of oxygen, that really made a significant difference in the pain in this wound. And she did allow me to remove the eschar. A few days later, you'll notice that the granulation tissue is looking more red and moist in appearance. And that moist appearance is very typical when you're treating someone with CDO. It does seem to hydrate well and really creates a great bed for wound healing. This progressed on. You can see how as the slough is starting to soften a little bit more, and the peri-wound, you can see the edges are starting to epithelialize, and the wound actually is starting to contract on the sides. It never went down a lot on the top to bottom, but side to side it was contracting inward. But overall, I was very pleased with the health of it. The other thing that was really amazing about this young woman is she, when she first came in, she was placed in a ward and she kept her curtains closed. She wanted to sleep all the time and she wanted no one near her bed other than a few of us. And as time progressed over the few days that she was there, she actually came out from behind the curtains and started to interact with the other elderly women in her room, offering them water, talking to them, and was very engaged with people again. You can see by April 18th, things are really doing quite well, and the plastic surgeon was consulted and agreed to do some grafting. I saw her again. She was discharged, and I saw her again May 19th, and you can see that the graft took very well. As a side story, while she was on the unit, her family, whose relationship was somewhat strained, were in to visit her. She came and went in their lives as well. Her grandmother came up to me and she said, "You have given me back my granddaughter." Thank you.
Thank you, Kathy. Now it's Karen back, and I'm going to be talking about some really exciting clinical evidence that's developing and a few studies I'm going to review with you. So the first study that I want to talk about is a study that looked at cytokines, growth factors, and perfusion. And you can see the reference here if you would like to get the full paper. It's published in the International Wound Journal. So after 1 week of CDO, there were significant increases in cytokines. And these were changes relative to baseline. So the researchers looked at wound fluid before CDO was started and then looked at wound fluid levels 1 week, 2 weeks, and 3 weeks after the baseline study. And you can see TGF-beta has increased at week 1 by 820%. VEGF has increased by 430%. Platelet-derived growth factor has increased by 280%. And in 3 weeks, 53% of the subjects had at least 50% wound area reduction. The other things that happened with the wound fluid is IGF-1 increased by 660%, tumor necrosis factor alpha increased by 450%, interleukin-6 increased by 420%, and at 1 week, there were significant changes in TCOM from baseline, both medially and laterally. And this was very exciting. And it wasn't something that the researchers thought that they would find initially, but was discovered at week 1. And so this slide I know is busy, but you can see to the far left for visit 1 before CDO, there are the levels of the various cytokines and growth factors. And then look at visit 2. And typically what we're seeing here are more cytokines that are going up. But by visit 3, week 2, now we are seeing more of the growth factors going up. And by the 3rd week, now the wound fluid is starting to look more normal and not like chronic wound fluid, but more looking like an acute wound with the appropriate levels of cytokines and growth factors. The other interesting research that has been done recently in the US, and this is a pilot study, and these are interim results. And this was done by a surgical group out of Baylor College of Medicine. They were having a lot of problems with toe amputations, and they were having a lot of these amputation sites dehiss and open up. And so wanted to do a study to see what the impact of CDO would be over a closed amputation site. And so you can see that the incidence of tissue necrosis with CDO was 0 versus 43% in the control group that just got the normal standard care. And the healing rate was significantly higher in the CDO group, 75% versus 29% in the control group. And as well, wound length reduction was 70% greater in the CDO arm versus the control group. Now, I'm sure you're looking at the p-values, but remember, these are interim results. And so an acceptable p-value with interim results is 1.1. And what the researchers reported is a noticeable trend in favor of CDO to accelerate healing in surgically closed wounds and to reduce the likelihood of adverse events, which no clinician and no surgeon wants. Now, a similar study was done looking at anterior neck surgery and scar reduction. And so what they found was the incision length was 40% further reduced in the CDO arm. And if you think about these patients, these would be people that would have a very visible scar on their anterior neck. And so the cosmetic view is very important to most people. And so not only did we have a 40% reduction in incision length, but a greater than 10% scar reduction at 4 weeks. And so the researchers felt that using CDO may improve wound healing after anterior neck surgery and include better outcomes for scar visualization. Now I'm going to turn it back over to Rosemary Hill, who's going to be talking about another one of her cases.
Thank you, Karen. If for the sake of time, we'll move through this case fairly quickly, but this was my first experience with continuous diffusion of oxygen. It was a 49-year-old gentleman who had type 2 diabetes and not a very good hemoglobin A1C, as you can see. And so he presented with osteomyelitis, and we had him on IV piperacillin. Next slide. And things were looking not great. And so I included the orthopedic surgeon's note. It's the documentation from the chart, which said, it's looking that this area is going to need to be debrided. We're going to do an IND. There'll be a 5th toe amputation, but there's a fairly high possibility that he will need a baloney amputation. Obviously, we wanted to avoid that at all costs. So in the OR, I think I have some photos where you're going to see the actual debridement. This was actually, the chart indicates a final report where things were not good and he was a high-risk patient. And so there's a lot of concern. And of course, the patient spoke vehemently that we must not, regardless of what we found, we must not obviously amputate his foot. Next slide. So this is us in the OR doing a debridement, and right away, following debridement, we had negative pressure application, and we continued to do that for quite a while, but they're just really, we weren't seeing much in the way of results. And when I say that, we weren't seeing a lot of granulation tissue in the wound bed, and you'll see what I mean by the next slide, where the wound bed just was quite pale. And so finally, we began the continuous diffusion of oxygen. So when you see the slide of December 5th, that was after 2 weeks of negative pressure wound therapy. So we just were, it was nothing happening, no granulation tissue. And then we began the oxygen therapy, and it was slow to begin with, but we started seeing the edges begin to pink up. And so we persisted. We did tend to change the dressing every 2 days, because when you do use continuous diffusion of oxygen, you get more exudate. And so it was a relatively simple dressing change. And we tended to use some some methylene blue and gentian violet. Next slide. Again, this is now only several weeks later, but you're definitely seeing the transformation to that wound bed. And the next slide. And this is, as Kathy mentioned earlier, that red tissue, maybe it looks on the picture as if it's hypergran, but it's actually very sturdy, robust granulation tissue, and it is not that friable. And so we persisted, and now we're just a month out, and we've got this gorgeous wound bed. And indeed, it's looking very optimistic at salvaging. Next slide. We continued on. At some point, some might say, well, did you consider going back to negative pressure wound therapy? But we were making such progress at each change that we felt we would just continue with the continuous diffusion of oxygen. And he was becoming very comfortable with the device, charging it. And he was mobilizing, but we made sure there was no pressure to that area. And finally, by March, we're really looking, by February 18th, it's really closing up. He's now in the community. The community nurses are changing his dressings, generally Monday, Wednesday, Friday. And then ultimately, his wound closed. That's March 10th, and he eventually closed, and he remains closed. So that case was now over a year plus. And so I'm very excited to say that here we are in April 2021, and he continues to have both his feet walking around. So it was a very, very positive outcome, of course, for this gentleman. He occasionally gets little wounds on his other foot, and he'll say, "Hey, Rosemary, do you think you should get that oxygen machine?" And but I say, no, it's not at this point. We're not ready yet for that, but they've been more superficial. And that's the end of that case study. And I think that concludes our time with you today. But just in summary, let's just, touch base on some of those summary thoughts when we think of this modality. It is cost effective. It's certainly, my patients with the neuropathic foot and the lady with her breast didn't have considerable pain issues, but Kathy's patients did. And so it's really remarkable about the fact that people are using less narcotics when they're reaching for the continuous diffusion of oxygen. It is naturally also antibacterial, and there is full wound healing. You would wear it 24/7, and the unit is light, carrying case, and an easily sort of a chargeable situation for it. So the second generation models are much more user friendly. So at this time, we'll pause and we'll take time to answer any questions. We've attached our emails, but I really want to thank all of the NSWOCs across Canada and our WOCN colleagues in the States for taking the time out in their day and listening to us share our thoughts and experiences with continuous diffusion of oxygen. Thank you.